name is Dr. Khalifa. I'm an assistant professor at the University of Jordan and an American board certified family physician. Unfortunately, I am unable to be with you today due to family constraints. Today I will be talking about osteoporosis. I'm going to talk about precision therapy in postmenopausal women. Unfortunately, osteoporosis is a chronic disease. We have to understand that once the patients get diagnosed with osteoporosis, they will have the diagnosis forever. It's just like hypertension. When the patients get hypertension, they get treated with their medications. Even if they become controlled, they are still hypertensive patients. Today, during my talk, I will be covering the pathophysiology of osteoporosis. We'll be talking about presentation and signs and symptoms, diagnosis. We will understand the screening ages and who to treat, treatment modalities, as well as drug holidays for certain categories of medications and sequential therapy. Unfortunately, osteoporosis poses a clinical challenge. Most of the time, it does not become clinically apparent until a fracture occurs. That is why it's called a silent disease. 2/3 of vertebral fractures are painless, although patients may complain of the resulting stooped posture or height loss. Typical findings in patients with painful vertebral fracture can be acute pain after a small fall or minor trauma. We have to understand that change in posture or decreased height can cause some gait abnormalities for the patients, which renders them more prone to falls and further more aggressive fractures such as hip fractures. Let's talk a little bit about the pathophysiology of osteoporosis. Osteoporosis is multifactorial, with an interplay of genetic, intrinsic, exogenous, and lifestyle factors. The hallmark of osteoporosis is a reduction in skeletal mass caused by an imbalance between bone resorption and bone formation. Under physiologic conditions, bone formation and resorption are in a fair balance. A change in either, that is, increased bone resorption or decreased bone formation, may result in osteoporosis. We have to understand that osteoporosis can be caused by a failure to build bone or reach peak bone mass as a young adult and by bone loss later in life. Accelerated bone loss can be affected by hormonal status, as occurs in perimenopausal women, as well as age among men and women, or it can be secondary to various disease states and medications. Aging, loss of gonadal function are the two most important factors contributing to the development of osteoporosis. Studies have shown that bone loss in women accelerates rapidly in the first years after menopause. The lack of gonadal hormones is thought to upregulate osteoclast progenitor cells, which leads to decreased bone formation and accelerated bone resorption. So let's talk a little bit about physiology. Bone is alive. There is constant osteoclastic bone resorption, and it's tied together to osteoblastic activity, which is responsible for bone formation. The two processes are tied together and talk to each other. And those are the targets for our treatment modalities. Most of us are in a normal homeostatic status, where there is no net gain or net loss. With aging, there becomes an imbalance, and it can occur also due to other disturbances in hormones. So there is bone loss that occurs after midlife due to hormonal imbalance. Postmenopausal osteoporosis is for a large part the consequence of both quantitative and qualitative bone alteration induced by estrogen deficiency, which occurs within the first 5 years of menopause. We have to understand bone is a strong estrogen-dependent tissue, and estrogen plays a role in acquisition and maintenance of bone mineral content throughout life. One of the main issues of osteoporosis is not attaining peak bone mass. Peak bone mass is defined as the maximum BMD achieved by age 40 as measured by DEXA. Bone mass peaks around the 3rd decade of life and slowly decreases afterwards. A failure to attain optimal bone strength by this point is one factor that contributes to osteoporosis. And this explains why some young postmenopausal women have a low BMD while others have osteoporosis. Women attain peak bone mass at the proximal femur in their 20s and at the spine around 30 years of age. Annual rates and cumulative amounts of BMD loss are usually greater 1 year before menopause and through 2 years after. Nevertheless, a lot of factors contribute to attaining peak bone mass, such as nutrition, physical activity, as well as hereditary factors which play a role in determining an individual's peak bone strength. The two most important risks for osteoporosis are having a previous fracture and age. We have to understand that the risk of osteoporosis increases with age as BMD decline. There are two types of osteoporosis: primary, due to postmenopausal and senile type of osteoporosis, which is common in persons after age 70, as well as secondary causes such as genetic hypogonadal osteoporosis, deficiency and malabsorption, inflammatory and neoplastic syndromes, as well as due to drugs. Although bone loss is common among women and it begins slowly and speeds up around menopause, we have to look for secondary causes of osteoporosis among most of our patients in order to treat any aggravating factors. There are multiple risk factors for osteoporosis, and it includes advanced age, seizure medications, which are common among our patients, thin build, female sex, use of alcohol, previous fracture, thyroid disease, or subclinical hyperthyroidism, which can be induced by medications that we give to the patients, family history of osteoporosis, steroids, inactivity, smoking, and genetic factors such as family history of osteoporosis.
The gold standard for measurement of bone density is through the DEXA scan. Another option will be biochemical bone markers, but it is mostly used to monitor treatment and for research. Quantitative CT scanning may be useful in identifying also fracture, and it is used also to identify areas with healing fractures. It measures volumetric bone densities of spine. It may be used in evaluation also of metastatic bone disease. Compared with DEXA, quantitative CT scan has a comparable cost and precision. The problem is the amount of radiation exposure with the CT scanning Sometimes it is used in rural areas where there is no BMD machines. Another option is using the quantitative calcaneal ultrasound. It's a low-cost portable screening tool. It has the advantage of not involving radiation. It is not as accurate as other imaging methodologies. Can be used to monitor skeletal changes over time, and it uses different z-scores than the one used with DEXA. Another option is you doing an MRI and bone scanning.
As mentioned earlier, measurement of bone density is through a DEXA scan, which is the gold method for the measurement of BMD. The machine should be FDA approved or EMEA approved. Calibration should be done annually, and the certified technologist should be running the scan, and a trained physician should be the one writing the report. Usually we look for vertebral fracture, which can be scanned separately or can be done as part of the DEXA machines, and most of the modern machines have a vertebral fracture assessment available. There's also something called trabecular bone scans, which gives us some information about the quality of the bone itself and its strength, and it can be added to certain machines which give also some information about the quality of the bone itself. The best site for BMD measurement is the hip BMD, which measures the osteoporosis at the hip, and this is the best to predict mortality and morbidity. In contrast, the lumbar BMD is used more to monitor treatment.
According to the WHO, the criteria to define osteoporosis are calculated through T-scores values as within 1 standard deviation of mean BMD value in healthy young adults. So if the patient has a T-score of -1 to -2.5 standard deviation, that indicates osteopenia or low bone mass. If the patient has a T-score of less than 2.5, then this indicates osteoporosis. Having a T-score of -2.5 with a fragility fracture indicates severe osteoporosis.
Recently, the American Academy of Clinical Endocrinologists updated their diagnosis for osteoporosis. It includes patients that were diagnosed through the WHO criteria, as well as patients with then the osteopenic range with a fragility fracture. A fragility fracture is a fracture that is sustained from a force similar to that from falling from a standing position, which includes patients within the osteopenic range with a fragility fracture in the proximal humerus, pelvis, or distal forearm, which is a Colles fracture, as well as patients with a high FRASCS probability score. It also includes patients with low trauma spine or hip fracture regardless of their bone mineral density. We need to mention what is FRAX. FRAX is a clinical tool for assessing the risk of fracture in patients with osteoporosis. The FRAX score can help doctors identify patients that might need additional support and have a higher risk of hip or vertebral fracture. FRAX score is usually country specific and is developed to calculate the 10-year probability of a hip fracture and a 10-year probability of a major osteoporotic fracture. Now, who do we screen for osteoporosis? We usually evaluate postmenopausal women aged 50 and above for osteoporotic risk. We usually start by a detailed history, physical exam, clinical fracture assessment risk, which is the FRAC score, as well as sending the patients for a BMD. The American Academy of Clinical Endocrinologists recently stratified patients into fracture risk categories in order to decide the pharmacological treatment that it will be used for the patients. They break them down into high-risk fracture and very high-risk fracture, and then decide the treatment according to their risk. Patients with high risk for fracture are the ones with a T-score of 2.5 and below, or the patient with an osteopenic range and a history of fragility fracture, or a low trauma spine or hip fracture regardless of bone mineral density, and a patient with a high FRAC score. Those patients, they are candidate for treatment with initial therapy as with alendronate, denosumab, or isondronate or zoledronate, which are anti-resorptive medications, as well as ibandronate or raloxifene. They also stratify patients as patients with a very high risk for fractures. This includes patients with a recent fracture within the past 12 months, or patients who developed a fracture while on therapy, or patients who are taking drugs that cause skeletal harm and developed a fracture, patients with a very low T-score below 3, patients with a very high risk for falls or injurious falls due to their gait or other issues, patients with a very high FRAC score such as more than 30% major osteoporotic fracture and more than 4.5% risk of developing a hip fracture. Those patients, they are usually candidates for bone-forming medications and such as romosozumab and teriparatide, as well as denosumab and zoledronate. What are the medications that are available for treatment of osteoporosis? They are broken down into anti-resorptive and anabolic or bone-forming medications. Anti-resorptive, they decrease the bone for resorption, and these are the most treatment agents available, and they include bisphosphonates, calcitonin, estrogen, and denosumab, whereas the anabolic medication, they stimulate bone formation such as teriparatide, allopuritide, as well as romosozumab. Bisphosphonates were first introduced back in the 1990s. They are the mostly used drugs for treatment of osteoporosis. They bind to hydroxyapatite in the bone and leading to reduce the activity of bone-resorbing osteoclasts. Examples include alendronate, ibandronate, and risondronate. Alendronate are 10 milligrams daily tablets or 70 milligrams weekly. Risondronate can be used monthly or weekly. Ibandronate is usually used monthly or every 3 months, and zoledronic acid, which is the IV form, it's used every year for the treatment or every other year for prevention in certain patients. Contraindication for the use of bisphosphonates include hypoglycemia, creatinine clearance less than 30, and patients with esophageal disorders or gastrointestinal intolerance or history of gastric bypass or inability to follow dosing requirements of oral bisphosphonates. Then, during that period, we suggest that the patient use intravenous bisphosphonates. Osteonecrosis of the jaw and atypical femoral fractures are safety concerns, but it is usually associated with patients with poor oral hygiene or with patients receiving very high doses of bisphosphonates for cancer treatment as well as treatment of osteoporosis. Bisphosphonate holiday. The American Academy of Clinical Endocrinologists recommends that If fracture risk is no longer high or the patient has remained fracture-free for a while, then we can consider a drug holiday after 5 years of treatment with bisphosphonates. If not, then treatment should continue for an additional 5 years. If the patient is on zolondronate, which is the IV form, we can consider a drug holiday after 3 years of treatment. We have to understand that atypical fracture risk is related mainly to the length of treatment, and sometimes just getting a simple drug holiday will decrease the risk of atypical fractures. Those medications stay in the bone for years and they can convey some protection even during the drug holiday. Denosumab is a monoclonal antibody. It is used as a subcutaneous injection every 6 months, and it can be used in patients with renal insufficiency. When treatment with denosumab was stopped, it was noted that bone turnover markers increased to values above the baseline by 12 months after discontinuation, and protection from vertebral fracture is quickly lost, but the risk does not usually exceed that from before the treatment. Denosumab is usually used, as we mentioned, every 6 months, and it's very effective, and the efficacy starts 12 months after therapy. It is recommended that the patient take some calcium before treatment because it is contraindicated in patients with hypocalcemia, and usually we do not recommend any drug holiday. Following up the treatment of denosumab with the use of bisphosphonates is recommended. So if denosumab is stopped, we need to start the patient on bisphosphonates in order to prevent any bone decline after stopping denosumab. Calcitonin is also used and approved by FDA for treatment of postmenopausal osteoporosis. There is the nasal spray and injectable form of calcitonin. The main contraindication for its use is drug hypersensitivity. The raloxifene, which is a serum, it's sold under the brand name Evista. It is a medication used to prevent and treat osteoporosis in postmenopausal women, especially patients on glucocorticoids. For osteoporosis, it is less preferred than bisphosphonates, and it is used to reduce the risk of breast cancer in those patients who are at high risk. It also increases the risk of venous thromboembolic events. Estrogen and hormone replacement. Evidence has shown that estrogen stimulates apoptosis of osteoclasts and suppresses the apoptosis of osteoblasts. Although it was once considered a treatment of choice for postmenopausal women, it is only approved for prevention, and it is given to patients with high risk of osteoporosis in whom non-estrogen medications are not considered appropriate. Livial is a new hormone replacement regimen consisting of synthetic steroid hormones. Livial or Tibolone has estrogenic effect as well as progesterone and androgenic effect. It restores the hormonal balance and relieves vaginal atrophy as well as improves bone density and decreases vasomotor symptoms. Some studies have shown that it might increase the risk of stroke, and the information about invasive breast cancer is controversial among studies. Teriparatide or Forteo is a recombinant human parathyroid hormone that acts as an anabolic agent for treatment of osteoporosis. As mentioned earlier, it is recommended for the use in patients with a very high risk of fracture. It is recommended also for patients who are intolerant to bisphosphonates or previous osteoporosis therapy, as well as patients who failed treatment and did not increase their bone mass. It is also indicated for treatment of patients with glucocorticoid-induced osteoporosis. Before treatment, patients need to get a calcium parathyroid as well as vitamin D level, and they should be monitored during treatment. It cannot be given for more than 2 years due to concerns about increased risk of osteosarcoma due to increased bone turnover. Abaloparatide, which is another parathyroid hormone analog, it was FDA approved in 2017 for the use in women, and 2022 was introduced for the use of osteoporosis treatment in men. It is indicated for the use in patients with very high risk of osteoporosis, and it does have an increased risk of osteosarcoma, and it is not recommended to be used more than 2 years. Romosozumab, this is the newest drug on the market. It is a monoclonal antibody that binds and inhibits sclerostin and thus increases bone formation as well as decreases bone resorption. It is the most potent drug currently in the market. It was first approved in 2019 for treatment of osteoporosis for patients with a very high risk for fracture. It carries a black box warning regarding increased risk of myocardial infarction and cardiovascular death, and should not be initiated in patients who have a myocardial infarction or stroke within the past year. We have to understand that osteoporosis is a chronic disease. Because bisphosphonates accumulate for prolonged periods of times, we can offer the patients drug holidays in order to decrease the incidence of osteonecrosis of the jaw as well as atypical fractures. Denosumab and anabolic agents need to be followed up by an anti-resorptive agents such as bisphosphonates. What do we consider as a response to treatment? One of the ways to look at response is to check the change in the DEXA and to look if there is an improvement in the T-score for the patients. Another option is to look at the bone turnover markers and see if there is an improvement in the numbers. We need to understand that, again, this is a chronic disease and we need to follow up the patients continuously. Treatment failure may be defined as a decrease in BMD or recurrent fracture in patients who are compliant to therapy. When we look at the patient's numbers, if we consider one medication as a failure, we can upgrade the treatment to a bone-forming medications. Thank you.